Hello guys, welcome to Ankit Sunyalvits. Today I'll tell you how to take perfect history and how to do perfect examination for your peripheral vascular disease for lower limb. So let's start. So guys, peripheral vascular disease is itself a very broad term because when we say vascular disease, it could be your arteries or it could be vein or it can include your lymphatics. Generally, in case of artery, it be associated with ischemia and muscles would be involved like your Burgess disease, TIO, or your atherosclerosis. In venous, no muscle will be involved. It would be like your DVT, varicose vein. I have already discussed these two diseases in my previous varicose vein lecture. Lymph could be affected, could be lymphedema. So it's totally a very broad term. It can affect any of your peripheral vessel, especially in lower limb, upper limb. So now we're gonna narrow it down because DVT varicose I have already taken. So in this video I'm gonna only talk about artery. I'll be restricting myself to only to lower limb to make it simple for you guys and easy to understand. For upper limb I'll be talking in my next video. So the better term for it is peripheral arterial disease. Here we have to see the common causes for lower limb ischemia. Mostly it could be acute or chronic. For acute, it would be thrombus, embolism, trauma, or aneurysm. Chronic could be atherosclerosis, or it could be thromboangiitis, obliterans, which we call as Burgess disease, or it could be collagen vascular disorder, or due to diabetes. In acute, most of the time they'll be asking you the 5 P's for acute limb ischemia. Most of the time in the exam, acute cause of lower limb ischemia won't be given to you because basically they will be managed urgently. For chronic, atherosclerosis and thromboangiitis obliterans is commonly seen. So before we move ahead, I want you guys to understand the difference between atherosclerosis and thromboangiitis obliterans. Just to tell you the difference in short, atherosclerosis is found in old age. They will have hypercholesteremia, which will thick their blood vessels. It will affect the large size blood vessels. It would be associated with obesity, diabetes, hypertension. In starting, it would be unilateral and later on it will convert to bilateral. Burgess disease commonly found in young patients. It would be associated with tobacco or smoking. Smoking is a risk factor for atherosclerosis and Burgess disease, but it is more common with the Burgess disease. It would be found in low socioeconomic status patients. In Burgess disease, it will involve the medium blood vessels and generally it have a triad. It will have a Raynaud's phenomena, it will affect the medium to small size blood vessel, and it will have thrombophlebitis. Thrombophlebitis is seen generally in 30% of Burgess disease patients. So overall, it will form a triad. I would just like to tell you guys that there is something called Shiona's criteria for Burgess disease. In this, if there is history of smoking and if there is an onset before the age of 50 years, there is involvement of small to medium size artery, generally infrapopliteal artery, and there is absence of risk factor for atherosclerosis like diabetes or hypertension, so most likely you can call it as Burgess disease. So now let's moving on with the history part. In history, the first thing is to ask the name just for the identity, then age. As I already told, Burgess disease is common in young patient, atherosclerosis in old. Gender, Raynaud's disease is more common in young females. Generally, Burgess and atherosclerosis is more common in males. Occupation, education, hailing from. You can even mention the socioeconomic status. As I told, Burgess disease is more common in low socioeconomic status patient. Then you have to mention the chief complaint in chronological order. You have to mention the complaint for which patient have come to the hospital. Then you have to tell about the history of presenting illness, something like that. Patient was apparently well this many months or year back. When he noticed discoloration of his foot, and then he went to this hospital and then referred or something. Whatever is the small gist or short history, you tell it to the examiner. In history of discoloration of limb, we have to ask how was the onset, because it would be sudden in case of embolism. It would be spontaneous and gradual in case of Burgess disease, which we call as thromboangiitis obliterans, or in atherosclerosis, in Raynaud's disease. We have to ask about the site where it started, how is the duration, how is its progression, is there any history of trauma, because history of trauma would be there in case of diabetes associated with some mild infection. You have to ask whether there is any numbness associated on that area or any paresthesia is there. You have to ask the history of pain. As soon the patient says pain in leg, then there should be some common diagnosis which should come to your mind. In this video, we'll be discussing about peripheral arterial disease. You have to ask about the site. Why site is important is site will tell you where where are we thinking the artery is blocked. If the pain is there in foot, then it would be mostly lower tibial or plantar arteries are involved in, like in Burgess disease. If it is calf, which is most common site, it could be because of arterial occlusion of femoropopliteal junction. Or is it thigh, then at thigh it could be occlusion at the opening of superficial femoral artery, or at buttocks it could be occlusion of bifurcation of common iliac artery. Generally for gluteal pain, we have a differential diagnosis as sciatica. Sciatica is a neurological claudication, so it will have some neurological symptoms. Just stay with me, in few minutes I'll tell you the difference between arterial occlusion and how to differentiate between neurological claudication. Then in the pain we have to ask about the duration, what is the character, is it intermittent claudication or continuous at rest, radiation, aggravating factors or relieving factors. So generally in limb ischemia there could be two type of pain, it could be intermediate or it could be rest pain. Generally, it will start with intermediate pain. In that, pain would be there because of inadequate blood supply to the muscle, which will cause ischemia and accumulation of P substance, which will owe to the inadequate flow. So, the patient will have cramp-like pain, and usually in the calf or at the site of occlusion. In intermediate claudication pain will occur when the muscle is working, and pain will disappear when the patient takes some rest or when he do the exercise. The next type of pain which we see in limb ischemia is a rest pain. In this, pain is there which is continuous in nature. It is aching pain. It is very severe. Generally, it is called as cry of dying nerves. It is called so because that nerves are dying, and it involves the vasa nervosum, which causes severe pain. This pain is very severe, especially in the night, because in the night when we sleep, our heart rate decrease, our cardiac output also decrease. When the cardiac output decrease and the patient limb is also at his heart level, there is severe hypoperfusion which will aggravate his pain on his limb, and there are several cases reported where because of this severe pain patient even committed suicide. Generally what the patient do is they will keep their leg hanging from the bed, so the gravity is working and little bit pain is relieved, and usually it will be there in the distal part and patient will be very sensitive. So for intermittent claudication pain we have grading, Boyd's classification. In grade 1 there is no pain at the rest, patient walks for some time and after some time he feels the pain when there is accumulation of P substance. As soon he continues to walk or continues to do his exercise, the P substance which is collected, it get washed away from the site and the pain is relieved. Grade 2, pain is there but patient is able to tolerate and he can walk with the limp. Grade 3 is patient is compelled to take the rest, so his pain is relieved. And last stage, which some people call it as grade 4, in which pain is there at the rest. So after taking the history of pain, we can classify it as intermittent claudication pain. Then we have to grade it according to the Boyd's grade classification. Then we have to ask about the claudication distance. What is claudication distance? It is a distance which patient can walk without feeling any pain. You can generally ask it initially how much was it and how much is it now. Generally if the patient says I was able to walk up to 1 kilometer previously, like 1 year back, and now I can't even walk 10 meter, so what it denotes is that claudication distance is reducing. If the patient was having a thrombus 1 year back which was blocking his vessel, has now gradually increased and now the patient can't even walk up to 10 meter. So the reduction in claudication distance shows us that there is an increase in the size of thrombus. If the examiner asks how can you practically confirm the claudication distance, then you can practically confirm it by making the patient to walk on treadmill. There we can count how much the patient have walked now. So next is the effect of application of warmth or cold. When the patient applies warmth, if the pain is increasing, it indicates there is symptom of arterial occlusion. When the patient apply cold and there is increase in pain, which denotes it could be a underlying Raynaud's disease. Here we have to ask the history of Raynaud's phenomena, in that when the toes or fingers get exposed to cold, it will show pain and pallor. Then after some time it will show a bluish discoloration. So as I told you, I'll tell you the difference between arterial and venous and neurogenic claudication. This is very important here. You must know this before moving ahead, because every examiner will ask you how did you differentiate between is it a arterial claudication or a venous or a neurological. So generally in arterial, as I told, cause could be a Burgess disease or atherosclerosis. Generally the pain will increase on walking, and after certain time the pain will relieve when the patient keeps his leg hanging or he takes rest. The pain will increase on limb elevation as the perfusion in the limb will decrease. In case of venous claudication, there is inadequate venous drainage, like it could be because of varicose vein, which will have dull kind of pain. DVT will have bursting kind of pain. In varicose vein, pain will relieve when the patient is raising the limb, because when the patient is raising his limb, the venous blood will go back and it will relieve his pain. The complication could be venous ulcer. Here the complication could be arterial ulcer. In neurological claudication, here it could be because of like nerve compression, or because of slip disc or Cordic vena syndrome. Here the pain would be there in the first step, or in the initial step only the patient will have pain, and pain would be along the nerve and it would be diffuse radiating type, and the pain will get relief when the patient makes certain postures like bending or any posture which relieve the compression of the nerve, and the peripheral pulses would be normal everywhere in neurological claudication. Where in arterial claudication, the arterial pulses may not be normal. Don't be shocked or don't get nervous. It's just names. Already people find peripheral vascular disease as very complicated. I want to make it very simple for you guys. This is just what other syndromes which can mimic like your arterial claudication. So the next is your history of ulcer. If there is an ulcer present in the patient limb, as I told, arterial occlusion can lead to arterial ulcer. When the patient says leg ulcer, there should be some differential diagnosis coming on your mind. But it could be, you have to ask, how did it start, what is the duration, where is the site, is there any history of trauma, how is the progression, is it associated with pain. Just let me tell you, arterial ulcer will be very very painful, and generally the common site would be tip of your toes or your fingers. The distal part of your body will be most affected. Then we have to ask the history to find whether there is only this one artery is involved, or there is any involvement of any other artery also. So like we have to ask the history of fainting, transient blackouts, which will indicate there is some cerebral vascular disease or cerebral vascular some pathology. You have to ask about any history of chest pain, which can indicate cardiovascular disease or myocardial infarction, heart attack. Paresthesia or weakness of in the upper limb. We have to ask history of blurred vision, which could be there if ophthalmic vessel is involved. We have to ask history of abdomen pain or any GI symptom which will indicate a mesenteric ischemia. Then we have to ask some special other history, like we have to rule out any fever, because fever could be there in case of secondary infection in wet gangrene. There would be other causes for fever too. We have to ask the history of superficial thrombophlebitis, like is there any pain, tense and tender thick veins, which would be there in case of thromboangiitis obliterans. Then we have to ask about the past history. We have to ask whether the patient have previous any heart attacks or any embolic stroke. We have to ask any history of such previous episode. We have to ask about any major ailment in the past. We have to ask any history of surgeries like amputation. If the patient tells, yeah, previously my left limb was amputated, now I have come with the right limb having the same problem, so definitely it tells us that previously also the patient is suffering from peripheral vascular disease from very very long. That's why his left limb was cut and now the patient is presenting with the right limb. And if there is any lumbar sympectomy done for the pain relief, in this patient, if you do the examination, you can even find a scar on his lumbar area where sympathetic nerves are cut down to relieve the pain. Then we have to ask the personal history. In personal history, where we have to ask whether he's married or he's having children or not, because generally patient may be impotence, like they could failure in erection. If there is bilateral internal iliac artery occlusion, or there is a saddle thrombus at the bifurcation of aorta, which we call it as Lerchier syndrome. Then you have to ask the history of smoking. Smoking history you have to take in very very detail, like when he started smoking, for how long he has been smoking, is he still smoking, when the last time did he smoke. You have to ask about any cardiac problems. You have to ask about any diabetes or hypertension. As I told, it would be associated with atherosclerosis. Or we have to ask about any allergy to any drug for the treatment part. You have to ask about the family history. Is there any such illness in family, because generally atherosclerosis may be familial. Then we have to summarize your history. Let's move on to the examination part. Patient is comfortable at rest with his leg hanging down below the level of his bed, and then you can mention whether he's conscious, he's cooperative, oriented to time, place, person, his build, nourishment. Then you have to mention pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or any pedal edema. You have to mention his vitals. Here BP and pulse rate is very important, because there will be low BP and high pulse rate in case of acute ischemia. Generally in chronic there won't be any much significance, because body get used to it. There is collateral blood vessels formation in chronic ischemia. In pulse you have to mention about whether all the peripheral pulses were felt or not. I'll tell you about all the peripheral pulse palpation at the end of this video. About the vessel thickening, you have to mention, because vessel thickening will be present in case of atherosclerosis. Then you have to examine the other system, like cardiovascular system. You have to examine whether there is any mitral stenosis or any pathology which can cause embolism, dislodgement. We have to examine respiratory system. We have to do the abdominal examination. Then you have to do a spine and cranium examination. Then we have to do the local examination. In local examination, first is inspection. In inspection, make sure you expose the patient fully. Both the limbs should be nicely exposed, because we have to compare with each other. In local inspection, we have to mention about the attitude of the limb. Generally most of the time patient will hold his limb with both of his hand. That is the most common attitude of the patient you will find. Then you have to look for any deformity. Is there any missing toe or any amputation? Then you have to look for muscle wasting in thigh, in calf, or in foot. The best way to comment upon muscle wasting is you measure his limb girth 2 or 3 inch above his tibial tuberosity, means below the knee and above the knee, and then you mention it to your examiner. According to your measurement, you are telling the right side is having muscle wasting or left side is having muscle wasting. Then you comment about the color change. It will be pale in case of acute arterial occlusion. It will be congested or purple color in case of severe or pre-gangrenous state. Then you have to talk about sign of ischemia or arterial insufficiency. In this, generally most of the time examiner will also ask you what are the signs of ischemia or arterial insufficiency. Then you have to mention thin and shiny skin. There will be diminished hair growth. There will be loss of subcutaneous fat. There will be trophic changes in nail, like something like brittle nails. There will be minor ulceration in pressure areas like heel, malleoli. Then you have to look for gangrene. There are signs of gangrene. Initially skin will be pale, then later on it will become a black skin. On palpation, there are some certain signs of gangrene, which is loss of temperature, loss of sensation, loss of pulse, loss of function. This is also one of the common viva question which they may ask you in PVD. Then you have to mention about the site and extent type of gangrene. The next concept which I want you to understand is the difference between dry and wet gangrene. Dry gangrene would be generally discolored, because due to the disintegration of hemoglobin it would be shriveled. It will give you a mummified appearance, and there will be clear demarcation line. Means if there is a dry gangrene of the foot, then you can clearly find a demarcation line in case of dry gangrene, and on palpation it will be very hard, skin will be cold. In wet gangrene it will be generally superimposed with inflammation, where you will find the skin is edematous, blood formation. There will be no clear demarcation line. There will be loss of sensation, and on palpation crepitus may be felt in case of gas gangrene. Then after checking the type of gangrene, you have to comment on the line of demarcation. As I told, line of demarcation is a junction between dead and normal tissue. You have to mention its level. Like here in this picture I can tell the level is up to the base of third toe, and then you have to talk about its depth. Generally it be extended to skin and subcutaneous tissue, but in certain cases you can even find the line of demarcation is also demarcating the muscles and bone also. Then you have to comment about the limb above the demarcation line, means the area above the demarcation line, whether it looks pale, congested, or any edematous or any skip lesion. This is important because this will give us information about any spreading infection or spreading gangrene above the line of demarcation. Then on inspection you have to do 3 tests: Burgess test, capillary refilling time, and venous refilling time. So let's see one by one. So first, in Burgess test, you have to do it in broad daylight. Patient will be in supine. You have to lift the patient limb with the knee extended. Normally here you can see one angle is formed between the table and the limb which is lifted. So this angle is called Burgess angle, or we can call vascular angle. In normal people, when we make the 90 degree or even more than 90 degree, there will be guttering of veins, but there will be no pallor present. But in case of severe limb ischemia, even when we lift less than 30 degree only, we can find there is pallor of the limb and veins will be emptied and guttering will occur even in more than 10 degree. This test is generally not so reliable in case of dark skin patient. Then next is venous refilling time. It is the same when the patient is lying down. We elevate the limb and let the veins to be emptied. Then we keep the limb back flat on the bed. Then in normal patient, the veins will refill within 5 seconds. In case of limb ischemia, refilling will take more than 5 seconds. The next test is capillary refilling test. In this, we have to elevate the patient limb from the bed where the ischemic limb become pale. Then we make the patient to sit with the legs hanging down the bed. When the patient limb is hanging down, here we can see the normal limb will still look pink, but the ischemic limb will take around 20 to 30 seconds to become pink, which indicates severe ischemia. If the ulcer is present, then we have to mention about the ulcer on inspection. Generally, arterial ulcer will be on tip of toes and fingers. They may be multiple, but they will be irregular in shape. They will be deep, penetrating deep fascias, no pigmentation around it. Then next, moving on to palpation, the first and most important part is the local temperature. Checking the local temperature is very important. We have to check the local temperature with the back of our fingers, because back of our fingers contain lot of cutaneous nerve endings, which makes it very sensitive. So we have to compare it between both the limb, normal and abnormal limb. The best way to start from the foot, then assess the whole limb gradually till the up. If it is cold, it indicates ischemia. If there is increased warmth, then it may indicate infection or inflammation. Like here, if we see, if the level of demarcation, for example, if in this patient is still here, but the level of coldness is up to here, then we will do the amputation till the level of coldness, not up to the level of demarcation. So the checking the level of temperature is very important. It will tell you the extent. Next, we have to look for any local tenderness. Then we have to examine the gangrenous area. In gangrenous area, we have to mention about its site. We have to look for any sensation loss on the site. We have to mention about its tenderness. Is any local crepitus felt, which indicate gas gangrene. We have to examine the area above or adjacent to the gangrenous area. We have to then palpate along the line of blood vessels like great saphenous vein or short saphenous vein. If there is any tenderness along the veins, it indicates recent thrombosis. If there is any pitting on pressure, which suggests edema, which could be there because of inflammation or thrombophlebitis. Then on the palpation of limb, we have to check for the movement of joint, interphalangeal joint, mid-tarsal joint, movement at ankle, knee, hip, everything, because they may be lost in case of gangrene. Then is the nerve examination of the lower limb. Here we have to do the motor system of the lower limb, which will include the tone, bulk, power of the muscle and joint. Then we have to do the sensory of the lower limb, crude, fine touch, pain sensation, temperature. This will be more discussed in when I'll make a video on central nervous system. Generally, ischemic limb will be hypersensitive due to irritation of nerve endings. Then you have to examine the regional lymph node because of any infected ulcer or any lymphoma. Then you have to do the palpation of arterial ulcer if it is there. Then you have to do capillary refilling test on palpation. In this, you have to press the nail bed or the pulp of the toes or finger for few seconds. Then you have to release it. You have to look for rapid filling in case of capillaries. In case of normal people, there will be rapid filling of capillaries. This capillary refilling would be delayed in case of peripheral vascular disease patient. Then you have to do a venous refilling time, which or we call as the Harvey sign. In this, we have to empty the segment of vein by milking it. We have to release the distal finger and we have to note the time required for filling of the vein. In normal people, the refilling gets immediately when on releasing the distal finger, but in case of ischemic limb, this venous refilling time will be prolonged. Then we have to do a crossed leg test, or we call it as Fuchs test. In this, patient is asked to sit with his crossed leg, so the popliteal fossa of one leg will lie against the knee of other leg. Then we have to divert the patient attention by talking to him or taking his some history. The important thing is we have to divert the patient attention, because if we don't divert his attention, he will keep all his focus on his legs and then our test will fail. When we divert the patient attention, if there is any popliteal artery pulsation, then we can see the oscillatory movement of the top foot, which we have to confirm by checking his pulse. If there is a synchronization, then definitely it is due to popliteal artery pulsation. If there is no oscillatory movement, then mostly popliteal artery is blocked or there is some technique fault. Just to mention you that there is something called reactive hyperemia test. In this test, we inflate the sphygmometer around the cuff and inflate it to 250 mm of Hg for 5 minutes, and then a pallor will appear. Then we release the cuff. In normal person, the red flush will appear within 1 or 2 seconds. But in case of severe ischemic limb, this duration will increase. So generally it is very painful. So most of the time we do not do this test. Then is the palpation of blood vessel. This is the most important part. If there is any obstruction of the vessel at this level, then we cannot palpate any pulse. Generally it's a common sense. If there is occlusion at this level at the top, then below it we cannot feel any pulsation. But exception to this is if there is any good collateral circulation, then we can palpate the artery below it despite of occlusion, because the blood will flow from the top to bottom with the help of collaterals. So if there is any expansile arterial pulsation which indicate an aneurysm, if there is a firm and tender artery which may indicate a embolus in the artery, if the artery is felt as soft, non-tender, non-pulsatile, most of the time it means the thrombus is above it. Then is the unmasking of the preliminary stage of arterial occlusion. In this, in a peripheral vascular disease patient, if the previously artery was palpable but it will disappear after the exercise, then is the palpation of peripheral pulses individually. This is very important. Most of the time examiner will ask you this. Carotid artery is palpated at the medial border of sternocleidomastoid at the level of upper border of thyroid cartilage. Remember, whenever you palpate carotid artery, palpate it one at a time. Do not palpate both the carotid artery at one time, otherwise patient will go for syncope or he may even die, and then you'll be jailed, which is not good. One basic you have to understand is artery is palpated against the hard surface. It means if it is a bone, a very tight or hard surface, when we put our fingers, we try to palpate it, then it is palpated against the hard surface. It means against a bone. So common carotid artery is palpated against the C6 tubercle, which we call as Chassagne tubercle. Then is superficial temporal artery, which is palpated in front of tragus over the zygomatic bone. Then is the subclavian artery, which is palpated at the supraclavicular fossa at the level of midclavicular point, with the patient shrugging the shoulder to relax his deep cervical fascia. Then for axillary artery, which is palpated in the lateral wall of axilla against the shaft of humerus in between the two axillary fold. Brachial artery is palpated in front of elbow medial to the tendon of biceps brachialis. For radial pulse, which is palpated in forearm just above the wrist joint in between the tendon of flexure radialis carpi and lateral border of lower end of radius. Femoral artery is palpated in the groin below the inguinal ligament at the level of deep inguinal ring, which is midway between the anterior superior iliac spine and the symphysis pubis. For posterior tibial artery, which is palpated in the medial aspect of ankle, midway between the tip of malleolus and the insertion of tendo Achilles, slightly inverting to the foot to relax flexor retinaculum. Alternate method is posterior tibial pulse may be palpated at the point 1/3 away between the tip of medial malleolus and the point of heel, slightly inverting the foot to relax the flexor retinaculum. For anterior tibial artery, the anterior tibial pulse is palpated in front of ankle, midway between the two malleoli and just lateral to the extensor hallucis tendon. For arteria dorsalis pedis pulse, this is palpated on the dorsum of foot lateral to the tendon of extensor hallucis longus at the proximal intermetatarsus space. To palpate the popliteal artery, it is very difficult to palpate because it is neither superficial nor it run over any bony prominence which we can palpate over it. So it's very difficult, but still we can palpate in supine position or in prone position. In supine position, the knee is flexed up to like 45 degree, and then popliteal artery is palpated against the tibia in between the medial and lateral condyle of tibia by placing the thumb over the tibial tuberosity and palpating fingers kept in the intercondylar area of the tibia. To palpate the popliteal artery in prone position, knee is flexed, popliteal pulse may be palpated over the posterior surface of the lower end of the femur. Then this is mandatory. Do palpate the artery on right and left side, don't do it only on one side. And then the best way will be to make a full table of it, write all the arteries which you have palpated, and then right and left. And do not forget to draw a diagram. This is the diagram which I have drawn. Like here I have mentioned that popliteal and his arteries of his leg and foot is not palpable. Better to draw it on the patient case sheet also. This is very effective method. Then you have to do the auscultation. In auscultation, if there is any systolic bruit heard over an artery, which is due to the turbulent blood flow beyond the stenosis, if any continuous machinery murmur is felt over the vessel, that may be due to arteriovenous fistula. Then in the exam, do not forget to examine the normal limb also, and don't forget to examine his upper limbs for any involvement of any upper limb vessels. The test for the upper limbs or the causes I'll be discussing in my next video. Then you have to mention your diagnosis. It is like this is a case of peripheral vascular disease affecting the right foot with ischemic gangrene of the great toe, probably due to Buerger's disease involving the popliteal artery. To draw the diagram is very important in your diagnosis. Now the second edition for ENT, Opthel, Pharma and PSM is already out. Interested people can go and buy from Amazon website. People who have already bought the first edition, they can freely update it. Thank you for watching this video. Subscribe for more videos. Follow on Facebook. People who want the examination pro forma, the link is given in the description box. So see you guys in my next video. Tata, bye bye.